Hello, everyone. Welcome to Facility Compliance Think Tank. My name is Lance Woolf, and I'll be your moderator for today's webinar. And this is the first webinar in a series of 5 this fall. Today's subject is COVID-19 and the importance of understanding pressures within your facility. Facility Compliance Think Tank, or FCTT for short, as we like to call it, is a venture that was created and sponsored by Soleran. Since COVID has caused such an impact within hospitals, we decided to bring educational opportunities to you virtually to help during these times. Since many of you have had your regional local conventions canceled, we thought we would go out and help with the community. So what we've done is we've handpicked the nation's top professionals in their field to help with compliance and share best practices. So this webinar has 2 purposes. First is we're going to discuss best practices in the areas of life safety, infection control, and other compliance-related topics during COVID. And then second, this series of webinars was created to help professionals network together and share ideas. We want to make sure this network grows. So we want to take those best practices and we want to build upon them that helps professionals all around. A little bit about our members is we consist of directors and facility compliance leaders all over the country, and we focus on offering real-time practices throughout this webinar series. We have a couple additional resources for you as well. First is we have a leadership networking group that's located on LinkedIn. And then second, we have an online Q&A session or area on Soleran's website for any compliance questions you might have. And that's accessible at any time. A little bit of background on me. Again, my name is Lance Woolf. I'm the Director of Life Safety Compliance here at Soleran. And I'm a former life safety code surveyor for Joint Commission. I have about 17 years of experience in hospitals, all in acute care centers, and I was a director, senior director in those areas. Areas that I oversaw was engineering, emergency preparedness, safety, biomed, security, and environmental services. And then during those 17 years, I dealt with H1N1, SARS, Ebola, and now COVID-19. Today's speaker lineup is, first we have Tony Van Dyke, and he's the Director of Environmental Health and Safety for Thomas Jefferson University Hospital, and he's located in Philadelphia, Pennsylvania. Next, we're going to have Maureen Aldrich, and she's the Epidemiologist and Infection Control RN at Carson Tahoe Medical Center, located in Carson City, Nevada. And then after Maureen, we have Brian Crum. He's the co-owner of Facility Health Incorporated, which specializes in asset life cycle management for your facility, and he's located in Grand Rapids, Michigan. So we appreciate all of our speakers taking their time out of their day-to-day to provide us with knowledge on different topics, because I'm sure it's going to be informative for everyone here. Little bit of housekeeping items is each panelist has about 5 minutes utilizing PowerPoint slides. So take screenshots, but if not, then we're also recording the webinar and it's going to be emailed to you tomorrow in case you missed something. And feel free to use this webinar for a reference as in the future. After our speakers are presented, we have about 10 minutes for a live Q&A session. So use your Q&A button at the bottom of your screen to ask any questions. Please don't use the chat, use the Q&A. If your toolbar disappears, just scroll over your mouse and it will reappear. So with this Q&A session, we'll try to get to as many questions answered as possible, but if not, we'll follow up with you if yours isn't answered during the webinar. And any questions afterwards this is over, go to Think Tank Q&A online where FCTT members can interact and answer your questions. So that'll be on the last slide of this presentation, and we'll have the web address on it so you can utilize the slide. So with that, let's go ahead and get started on the webinar. We're going to begin with Tony, and Tony's going to talk about the current status in hospitals and the increased oversight of air pressures within the facility during the pandemic. So Tony, are you there?
Yeah, hey Lance, how are you?
Great, glad to have you here. I'm doing well. I'll go ahead and bring it over to you.
Okay, so thanks everyone for joining us. You know, it's been a real interesting time. It's been a real learning moment for a lot of us, even though we spent a lot of time in healthcare. Very interesting, and we got hit with this very fast. So we had to make some changes on the fly and really take some really close look at how we do business. Our concerns right away are, one, how we treat patients and how we protect our staff. We want to make sure under the OSHA General Duty Clause, we're not getting hit with something that we're not creating a safe environment for our employees. We all know, hopefully, that The best way to isolate patients is by using our air pressure. The difference between the room and the corridor, or the difference between the unit and the adjacent area. And I know Brian's going to talk quite a bit about that later, and the actual doing that and making that happen. But what I want to focus on in my 5 minutes is how we as facility managers basically had to step up and make some real quick decisions in doing this. So we're looking at, when COVID hit the United States in February, and if you look back, I mean, our first notification was in January. We were scrambling, and how do we take a surge? And you look at what happened in New York City, and how do you protect patients? How do you protect the patients, protect the staff? Yeah, there's ways to do it. We isolate, but you have to look at how much effort we can spend in a very short time, and how much money we can spend in a very short time to create negative pressure isolation room, because we want to make sure that that virus is staying in the room, and we're having as little spread of that virus throughout our facility as possible. So, sure, there was ideas that came up. Do we build isolation vestibules on the outside in the corridor? That was with limited success. Sometimes it worked, sometimes it didn't. So, you would try to move a piece of equipment through that, and all of a sudden, that plastic's getting ripped down, and the HEPA units get knocked off. The other thing was, do we make permanent changes? Do we get above the ceiling, change ductwork, and take rooms that were neutral or positive pressure and convert them to negative pressure? And one of the things we ran into here within our facilities was the time and the money that was going to take to do that. We got notified in January. We started to see the surge in New York City. After that, in late February, and then by March, we were starting to get patients and really ramp up at our facilities. So sure, it was the great idea of let's go change our systems, but what money was available and how much time did it take to do that? And a lot of risk management of how we do that, and is it worth doing? So sure, now we're in a downtime, and we've talked about this now. What areas now do we turn around and do we make negative? Do we make areas of the emergency department negative as a whole? Do we change rooms that were neutral or positive? Do we change them now? We know we can't, because of code changes, we can't have rooms that switch back and forth. That would have been helpful in this during the pandemic, but now we know we can't do that. So I suggest to any facility directors to really sit down with their infection control people, with their safety people, and say, how do we convert? Do we need to convert rooms? Do we need to make negative pressure whole units or suites, and work in that direction? Our success was we basically isolated our patients, used the negative pressure rooms we had, and in some cases we struggled because where we wanted to have COVID units, we might only have one negative pressure room on that unit. So we were able to turn around and say, okay, how do we make the unit safe for our employees? The key here is, do you make sure that you're limiting the contact with the patient, so that you don't have employees going in and out that door trying to make that area safe? Do you use HEPA units within the room to recirculate the air? The other thing that you can start looking at is, is there quick fixes? And I know right now we're up against a lot of supply chain issues. Do you use filtration within the room itself, within the supply diffusers, putting HEPA into that and using that? Again, that can be a little problematic and costly. And with our current supply chain issues, you may not be able to get those units and get them in time. So having the negative pressure rooms is key if you have them. I think the next step that facility directors, safety directors, infection control directors have to look at, how do we turn around in our downtime between, hopefully it's a permanent downtime and we don't have a surge coming up. How do we redesign? How do we renovate? and what steps do we take to keep our people safe and be able to treat the infectious disease that we're dealing with COVID and moving forward. So a lot of considerations there, and I could go on for a while, but those are the considerations that we're taking here within my system. So if you have questions, please put them into the chat, and we'll take our time to answer them. Back to you, Lance.
Great, thank you, Tony. That's great information for what you're going through, and it's nice to hear a different geographical perspective from your area, especially since it's such a huge geographical area as it is. So next, we're going to move on to Maureen, and she's going to talk about the specific changes infection control has made since COVID-19, and she's going to talk a little bit more about how air pressures directly affect patients. So Maureen, are you there?
I am. Thanks, Lance. Thanks for having me, everybody. My name is Maureen Aldrich, and like Lance said earlier, I am the hospital epidemiologist and infection control nurse at Carson Tahoe Medical Center. Coming from Philadelphia to where I am, we are far more a rural area, and sometimes being in a rural area can present challenges in and of itself. One of the things that when we thought about when considering environmental and engineering controls was that we looked at the initial screening of patients presenting to the ER. And we know that it's really important and vital to recognize potentially infectious patients, but the most challenging thing that we have recognized is that the symptomology keeps changing. And so we decided that we would develop some engineering controls to kind of mitigate the risk associated with potentially infectious patients presenting. And one of the things that you can consider, and we considered, is a dedicated pathway for symptomatic areas through triage. We developed an area that we would put our suspected patients into, and from the triage area dedicated a path for them to get from triage to that area. So that's something that you can do. And if that's not always possible, of course, the CDC guidelines do recommend putting a mask on the patient. We also would put a sheet around the patient and put a mask and a shield on the patient if we were unable to take them through that pathway, depending on where they presented in triage. If possible, developing a dedicated triage area is really important. Some hospitals are able to do that, some are not. We were able at one point to kind of shift all of our patients to one area to be doing COVID swabs. And then when they presented to the ER itself, dedicated an area for them to go to for triaging and treatment. And then of course, depending on where you are, if weather permits, where we are, we have 256 days of sun. You could do an outdoor assessment and triage area. We were able to put up a tent where we could funnel patients with symptoms into the tent, and then also have providers come out to the car and do assessments and swab patients. So those are different things that you can consider when you are working through engineering controls as far as patients being in the right place. And then there's always a question, why negative pressure for COVID? I don't think there's anything that says out there that it's definitely airborne. I think people go back and forth with that. But what we do know is that with emerging pathogens like SARS-CoV-2, which is our COVID-19, increased protective measures are really important. We know that the potential for transmission via small particles is real. And we know that these emerging pathogens can cause severe infections, and we don't have specific treatments or vaccines for them. So that's what defines an emerging pathogen. Also, that people don't have antibodies. It's brand new to our world, and so not having antibodies, we need to really treat these emerging pathogens as potentially lethal and really put measures in place to prevent transmissibility. So what we found is that as we went through this whole COVID experience, that aerosol generating procedures expel higher concentrations of the infectious respiratory aerosols. So coughing, sneezing, talking, and breathing, those are all elements of transmissibility. But when you take into account the patients that are presenting with respiratory infections, we're often doing suctioning, breathing treatments, intubating patients. And during those procedures, the amount of concentration is much higher. So we need to take the extra step in preventing transmission to our staff by putting them in an airborne environment, airborne isolation environment, which is negative pressure, and protecting our employees by having them wear the PPE appropriate to airborne isolation and transmission. So we know that with the negative environments and HEPA filtration, it removes the aerosol from the air, and that decreases the contamination of the environment, and the time a room must remain closed before it can be used again. So what that looks like is considering what happened in the room during that patient's stay. The amount of air the air inside the examination room, how long that remains potentially infectious, we really don't know. And it depends on a lot of factors. Like I said, how many air exchanges there are in the room for negative pressure, how long the patient was in the room, and if the patient was coughing, sneezing, or if we did that suctioning, intubating, breathing treatments, those kinds of things, there's going to be a higher viral load in the room. So when we look at negative pressure, we look at the number of air exchanges that need to happen to remove the contaminate. And when you look at 99% efficiency and 99.9% efficiency, the time limit is different. If we want to go to 99.9, which is definitely optimal, depending on the number of air exchanges you have in that room, you can see how long it takes to turn that room around and deem it safe for another patient or staff to enter it. So the typical negative air pressure room is 10 to 12 air exchanges per hour. So when you look at this graph provided by the CDC, you can really look at 28 to 35 minutes of time in the room that it takes to remove contaminants to a 99.9% efficiency. So 28 to 35 actually. And that's when you can bring people into that room without wearing any PPE. If you have the patient in that room and you need to go back in, or you need to emergently admit another patient, then definitely need to have the appropriate PPE going into that room. And then finally, some alternatives to negative pressure. So of course, like Tony was saying, not all rooms are negative pressurized. And we did go back and forth with making rooms a little bit negative pressure to the outside environment. And what we ended up doing is, while we could maybe make them a little bit negative to the outside environment, we were able to create anti-rooms. Our rooms are set up in cubbies, so we were able to create anti-rooms into the rooms that were neutral pressure. And that provided us an opportunity to have a place for people to don and doff appropriately. We were able to put air scrubbers into those areas, which would scrub the air, HEPA filtration, so that the rooms remained safe for people to come in and out of, and that the air coming out of them was HEPA filtered. So that was one option that we did that worked really well. And we actually use those now going back and forth depending on the number of positive patients that we have in the area. And it's worked really well for us. And that's all I have. So back to you, Lance.
Well, thank you, Maureen. That was great information, especially with all the air changes and being able to take some of the contaminants out. So we're going to move on to Brian now. And Brian's going to talk about the format and the process for creating an air handler layout that easily identifies areas served throughout the facility. So Brian, looks like you're on, so take it away.
Yeah, thanks, Lance. Appreciate everybody coming together to talk about this very important topic today. I am a currently recovering facility director, and what I do now affords me a lot of opportunities to see a lot of customers in different situations, different hospitals in different regions around the country. We've seen throughout this epidemic a pretty significant number of different scenarios, different solutions to provide negative space where there is a significant lack of negative space. And so I've got just a couple quick suggestions to go over, which you can put in place at your hospital and hopefully help you out. So first slide. Thanks. This is a quick example of what we would highly recommend every organization do. We've been in many different organizations, and it's surprising how few have information like this readily available. What you see here is a basic floor plan with all the mechanical systems identified, all the air handlers, and the areas served. This drawing is a good start to identify each area served by the air handler. I would recommend also putting in CFM for each air handler as well, and then also adding exhaust fans in the areas served by exhaust fan along with CFM on a drawing set like this. Now with this, I've heard stories of customers who have talked about trying to make negative rooms out of an existing room by even potentially pulling out a window and putting an exhaust fan in the window to exhaust it outside. Obviously, that's an extreme case, but we've seen a lot of really ingenious solutions to the problem that we're facing. You can't do anything like that if you don't have a good understanding of your mechanical system and its capabilities. If we were to open up a window to the outside and start venting air to the outside, how does that impact my air changes? How does that impact my balance to the rest of the hospital? How does that impact critical spaces outside of the rooms that we're talking about? If we share air handler space, we share exhaust, anything like that, obviously making a significant change to any type of system to try to accommodate negative air pressure is going to be affecting a lot of areas outside of that. And it's simply impossible to really develop a game plan of action either in advance or in an emergent situation without having a good, thorough understanding of what your areas are served, how they're served, how much airflow is blowing through there, and what the impact is of other adjacent areas. The next thing that we recommend as we work with limited staff, we talk about prioritization of preventative maintenance. If we could move to the next slide, please. And this starts with a thorough understanding of risk ranking assets. This here is an example of a risk ranking protocol or a solution that many hospitals have put in place, identifying risk categories such as utility classification, or what utility does this piece of equipment serve, risk application, what is the most likely outcome if this particular piece of equipment fails, maintenance requirements. Now this is both repair and replacement history, as well as preventative maintenance requirements, and then asset redundancy. Asset redundancy, we typically view as not just an N+1 type scenario, but how quickly could I get a system back in place if this particular piece of equipment fails? Now, starting out with risk ranking on all of your assets helps really identify and prioritize which assets are your most critical assets. And when we get into a scenario of limited staffing, we can identify which assets we should be really focusing our preventative maintenance on. This is kind of the start to an organized AEM program. This is the first step. And by doing this, by putting in a risk program such as this, it helps you identify and prioritize assets compared against other assets. A simple scenario would be an existing air handler that serves surgery versus an air handler that serves the front lobby. Obviously, a surgery air handler should risk higher. And what we would do with that is look at the risk application and potentially utility classification in the risk categories here and increase those. Now, comparison to that would be a front lobby air handler where we might reduce the risk score and lower risk application or utility classification. By having these risk scores at hand for each individual piece of equipment, this will allow us to identify which asset we need to focus maintenance on, both preventative and repair in a crisis such as what we've seen with COVID. Outside of that, we recommend a thorough analysis of all your assets. We recommend doing a full audit of all of your assets and applying these risk scores to them and identifying conditions. So in the event that we have to modify them and we have to increase capacity, we know what they're capable of. The worst thing that we can do is get an air handler. We need to crank it up, turn the freak drive up, and we run it beyond a point of failure. And we lose that air handler in a critical situation. So it's very important to have a good, thorough understanding of exactly what condition that asset's in, and then also the risk as we talked about here. That's all I have. Thanks.
Well, great. Thank you, Brian. That was very insightful, especially on the air handler layout. And you're absolutely right. A lot of facilities don't have that opportunity, and it's definitely a positive, aspect when you do. So what I'm going to do now is I'm going to take a few minutes. As I said earlier, I'm a former Joint Commission surveyor, and I'm going to take a few minutes and give the surveyor's perspective within the facility. We'll go over some possible questions that you're going to be asked by Joint Commission, talk about some of the virtual methods and compliance standard that's going to be used. So next question, or next slide, please. So first of all, let's go over the standard, and that's an ECO 20501 EP15. This is a standard that's directly related to Joint Commission. And this standard here definitely, it talks about all your critical pressures at the top here with your ORs, your Bronx rooms. And what's going to happen during your survey is obviously this is going to go through and check as part of your survey normally anyways. So they're going to go through with the venometer, which I have up as the top right. That's going to be the unit that they're going to be using. But what they're going to do is they're not only going to focus on these rooms as a normal part of your survey, you're going to get asked additional questions regarding COVID specific related issues. So one thing I do want to point out with this slide is at the very bottom, when you get down to your soil utility rooms and your isolation rooms that are off onto the floors, that's scored as a different level, but keep in mind that your top 4, any of those, if you have findings in those areas, that's immediately conditional. And next slide, please. So the survey focus right now is one thing that's just changed now, it just started, is the environmental care session is no longer part of Joint Commission survey sessions. They've done away with that completely. So what's happening now is you're going to focus more on your emergency management COVID session that's going to be mirrored together with your infection control. It's going to be inclusive of everything. Joint Commission just started doing full site surveys back this September, and they're hitting areas that have low areas of COVID, but they're going back to full surveys now. We are having staff on site. They still are working on some virtual aspects as well with the larger facilities. So depending on your facility, you could have either or now. As I talked about, the sessions are inclusive of emergency management, infection control, and then the focus of this session, though, currently is COVID throughout it's COVID discussion throughout the entire session. And they're asking specific questions in regards to your air pressure issues. What have you done to change your air pressure issues? What are you doing to document? And you're getting multiple questions with that. Additionally, they're talking about, on the emergency management aspect, they're asking the question on what is your triage process, as Maureen talked about. And then they're also asking you specifically on what you're doing to change your air pressures, as Tony talked about. So all these questions, be prepared for these as you're coming up on your survey. Infection control questions, they are going to include specific measures IC is taking. So they're wanting to know what the limit, what they're doing to limit exposure. And then they're also mirroring that together with emergency management, because they want emergency management to show that they're working directly with infection control and engineering, and you're not working in a silo manner. Next slide, please. So some of the questions you're going to be asked. The first thing you're going to be asked is give a quick overview of your hospital's state. This is going to include your staff, your facility, your supplies. They're going to ask what you've done differently to monitor your critical pressures on a consistent basis. And this is where you're going to want to be prepared to show your documentation. They want to see the processes that have occurred. And then they're going to want to see that you're just basically, you're following up with documentation. They want to make sure that you're just not just basically coming right off the top of your head with an answer. They're going to ask you about, have you changed your filter schedule? If you have, make sure that documentation is in place, because that's going to be checked. They're also going to ask you, what changes have you made to your supply chain process since the original PPE shortages occurred? Because obviously that's been a hot topic throughout this entire thing. Next slide, please. Additional questions are, what are you going to do to monitor and manage your staff for COVID? And they want to know specific processes in place. And this not only is going to be an IC question, this is going to be a departmental question. So as you're doing your rounding, even with the engineer, he's going to ask you that question, because he's going to want to know what specifically you're doing as a leadership to take care of your engineers. They're going to ask you, what changes have you made in your engineering areas as well to reduce the possibility of exposure, to the point of what have you done in regards to cleaning the areas to make sure that you're reducing that exposure and reducing that contact. They're also going to ask, what adjustments have you made since you're into your engineering maintenance program since the 1135 waiver was instituted? And they're going to want to show that you're doing in good faith, trying to get back onto your schedule. Next slide, please. So areas to focus now to prepare on. Well, as you've heard, the common theme throughout this is ensure your documentation on any changes in your maintenance schedule is documented. And so ensure your documentation it's organized, it's in place, and when they ask for it, that you're able to provide it pretty quickly. Make sure that if you're unable to keep your regular testing schedule on due to COVID-19, which has happened to a lot of people because vendors just not available, make sure you can speak about your efforts to maintain these with limited resources. And then show your documentation of any risk assessments that have been completed in conjunction. But you're going to want to show that your infection control was involved with this for pressure-related issues. Do an internal audit on your preventative maintenance program to ensure that your documentation is correct within your program. So what you're speaking to, make sure you're doing an internal audit to make sure that you're saying the correct thing. And then if you have an area where something was missed or not completed, just schedule the testing immediately. CMS during the state of emergency allows for adjustment on certain maintenance, and the only areas that you cannot adjust is that came out in the 1135 blanket waiver was the fire pump testing has to stay on schedule, your fire extinguisher monthly inspection, monthly elevator firefighter recall testing, your generator testing, and then means of egress due to constructions or alterations. Other areas are able to adjust it, but these are specifically the 5 areas that CMS, the blanket waiver, identified. Next slide, please. So that's it. So from this point on, we're going to move to our we've covered a lot of information, and we're going to open it up for question and answers. And so we're going to give you a minute to give some of your questions, ability to type in some of your questions, and we'll be more than happy to answer as many as we can. So it looks like we already have one in the queue right now. So this is going to be for Tony. So Tony, what suggestions do you have for facilities in facility design in the future?
I think the biggest thing for facilities designers in the future is one, and I think Brian, you'll agree with this, start now and assess your facilities, get an engineering firm on board, and start looking at your spaces. So if you're going to renovate spaces, look at those spaces and how you're going to renovate them. Work as a team, get your infection control people involved, get your infectious disease people involved, and get the caregivers involved and say, what do we need? And make your determination from there. If you can turn around and come up with some, and you may have to be creative, but you want a design professional to be able to tell you what you can do either with the units you have and the facility you have, or if you're building new, you want to make sure that the equipment and the design that's going in is going to meet what you need. So, your rooms, you have to look at your rooms, and you have to look at the size of your rooms, what the FGI guidelines are going to require. And then you're going to have to go through the mechanical code. You're going to have to go through the FGI guidelines requirements and say, how do I want this room to function? And don't wing it. If you have the time to do it right, do it right. Get a design professional in there who's going to design a system. The last thing you want is for you to, say we get hit again with another pandemic, or we see a pop-up of the COVID again. Turn around. You don't want to turn around and say, oh, that air handler that you just put in 2 months ago was undersized, or that fan was undersized, and you can't meet the requirements that you need. But it's got to be done with a design professional, and it's got to be done with all the players at the table from within your organization. Let me know if that makes sense.
Yeah, absolutely. Yeah. Thank you, Tony. Looks like we have another question in there, and this one's going to be for Brian. So what are the most requests you're getting for help currently from facilities directors?
That's a great question, Lance. For us, our landscape has changed dramatically over the last 6-7 months. our company was put in place to develop dynamic condition assessment and capital management, help our customers identify and get the capital that they need to replace infrastructure. Unfortunately, because of COVID, the bottom line's been hit so hard at so many of these organizations that capital isn't even in the discussion right now. I mean, there's a moratorium for the next year, maybe two, on capital expenditures. And so what we're getting is a lot of questions right now on the operations side. Staffing levels now are being talked about being cut if they haven't been cut already. And we know most operations department, maintenance departments kind of operate on a thin margin as it is. And so what we've really had to do is adjust our strategy and use a lot of the metrics that we have available to help justify and tell the story of why preventative maintenance and routine maintenance is so critically important, especially at this time where we're deferring capital. What we're able to show with a lot of our metrics from our customers is that as an average, for every $1 spent on preventative maintenance provides a return of about $40 on total capital replacement costs, but because of how preventative maintenance can adjust the life cycle and manage the life cycle of an asset. Cutting operational costs and cutting staffing only results in reducing preventative maintenance. And by reducing preventative maintenance, you're likely going to shorten the life cycle of your capital assets. So that's really becoming a hot button issue for us right now.
Great. Well, thanks, Brian. It's good to see your insight coming from the vendor perspective, because you're absolutely right. People are working with limited resources consistently now, especially in the facilities areas. So we have one more question, and this one's going to be for Maureen. And what's your biggest challenge for infection control with the COVID-19 response?
Wow, that's a loaded question. So as there's so many moving pieces with COVID, from the changes in symptomology, the changes in protecting patients, the changes in treating patients. I would say that the biggest challenge that I've experienced is managing all those pieces and then developing processes to address all of those moving pieces, and then communicating to the staff and to everybody the changes in the processes that we've developed to meet those challenges. It's been definitely a trying time, but everybody, at least for me, has worked really well together, and we just keep learning together as we go.
Great. Well, thanks, Maureen. And it looks like that's going to be the end of our questions for today. So it looks like that's the end of today's topic. We have one more that just popped up. And this will be for me, I believe. So the monthly pressure testing, the question is, the monthly pressure testing or expected for COVID areas, rooms, annual pressure testing required, expected if your policy is to do testing on all. Well, with this question here, with the 1135 waiver, it's basically, if you can follow your policy as close as possible with your testing or what you've identified, then you're following what you need to be doing. If you have some adjustments based upon you're having vendor issues, or you're having internal issues because of limited staffing and everything, then you once again, you want to be able to speak to that. You want to be able to show that documentation that it still is occurring, and you've had to adjust it for these reasons. And so that's going to be the biggest key, is just focus on that documentation and focus on that adjustment and why that's happening. And then, like I said, keep just following up with the good faith part of it to make sure that you're able to hit everything that you can. So it looks like now we're at the end of today's topic. I want to thank Maureen, Tony, and Brian for their time today. It's great information. We really can benefit from everything. And some reminders, we have an email coming to you tomorrow with the link, and we encourage you to share this information with colleagues. We want to get them involved and get together for our future webinars. Our next webinar is October 15th at 1 p.m. and that's Central Standard Time. And the subject is going to be possible changes in emergency preparedness. So we're going to have great speakers lined up, and the registration is already open and it's always free. So go to www.soleran.com/think tank. So we look forward to working with you again. We encourage you to use Facility Compliance Think Tank question and answers group on LinkedIn, and then to get your additional questions answered by the industry experts. It's going to include our panel experts as well from this webinar and future ones. So we want to remind everybody that this is an area to interact with the others, you know, as professionals in the field and as a panel, utilizing our panel experts as well. So this is going to conclude today's webinar. Soleran and our speakers, we want to thank you for your time again, and we look forward to seeing you in October. Thank you.